Good evening, everyone. Every year, thousands of children suffer with tonsillitis. A doctor would normally recommend a few days of bed rest and the symptoms should disappear by themselves. But when tonsillitis flares up again and again, the next treatment option might be to prescribe antibiotics and painkillers. For cases where tonsillitis flares up 7 times or more in a year, a doctor may refer a patient for a tonsillectomy to have their tonsils removed. Now, tonsillectomies are not rare. A recent study showed that of the 37,000 tonsillectomies performed in 2016 and 17, the vast majority of these, the patients experienced no clinical benefit. Now, when you consider that all surgical procedures carry a risk of major complications, not to mention the cost involved, this is a perfect example of an inappropriate surgical procedure, because it's not good value for the patient and it's not good value for the NHS either. My name's Marcus Dawson, and for the past 6 weeks, my project has been at NHS England using data to identify inappropriate surgical procedures. I've been working with the evidence-based interventions team, who last year published a list of 17 inappropriate procedures, including tonsillectomies, as well as varicose vein surgery and snoring surgery. Identifying these procedures requires clinicians to search through a wide range of evidence to develop rigorous guidance. This process is slow and labour-intensive, so the aim of my project was to develop data-driven methods to help facilitate this process. I've been working with the SUS database, which comprises the records of all hospital admissions in England. Each record contains information about the procedures performed and the diagnosis of the patients. Now, it's important to note that a procedure can only be considered inappropriate or indeed appropriate in the context of the diagnosis. Each record also has some information about the patient's age and sex, the area where they live, and where the treatment was performed. But there are also some major limitations with this data. For a start, we don't have access to information about GP appointments, prescriptions, or previous medical history, all potentially useful things for predicting inappropriate care. Another challenge is that we actually have a very narrow definition of what's inappropriate, and this is based off the list of 17 procedures. So I needed to come up with creative ways to identify inappropriateness within this data. Now, it turns out a good place to start looking is at geographical variation. And the rationale for this is if procedures are done at vastly differing rates across the country, that might indicate that some of these procedures are being done inappropriately. To dig a bit deeper into this, I analysed geographical variation across all the procedures and ranked these from highest to lowest. When we do this, we see some interesting things. Firstly, those procedures that show the highest levels of variation are the specialist procedures, like heart transplants. And this makes sense because they're done a lot, only in a few sites across the country. What we also see is that the procedures we know that are inappropriate tend to be bunched within this bracket in the middle of the list. A quick look of the types of procedures that occur most commonly in this list reveal or correlate well with what we know about inappropriateness within the literature. For example, endoscopies can be highly appropriate and life-saving procedures, but when there are safer alternative tests and treatments available, endoscopies are almost certainly an inappropriate option. This process of filtering the procedures in terms of geographical variation reduced our list from over 300,000 down to about 1,200. This is pretty good, but can we do any better? Well, as I mentioned before, one of the limitations is that we're working with a really narrow definition about inappropriateness. And for the remainder of the data, for want of a better phrase, this is really unknown. We know there's probably some inappropriate procedures in there. We know there's probably appropriate procedures too, but we don't have a definition for appropriate procedures, and we don't have any labels either. So how do we pull out the inappropriate procedures from this unknown portion of the data? Well, my approach was to build a random forest classifier and ask, can it detect the inappropriate procedures? And yeah, it performs fairly well at doing this, suggesting there is some signal in the data about inappropriateness. But what I did next was to say, when does the classifier incorrectly categorise procedures as inappropriate. In other words, what does the model see as most similar to inappropriate procedures that we know about? It's these false positives that might be our new inappropriate procedures. By combining the results of my classifier model and my geographical variation analysis, this has allowed me to refine my list of procedures, which has now been passed on to clinicians for clinical review. The classifier model allowed me to shorten the list by about a further 15% and has already made some suitable recommendations for inappropriate procedures, such as adenoid removals and hernia surgery. The impact of my work has been to develop a new method enabling clinicians to narrow their search for inappropriate procedures, and hopefully in the long term will save lives and deliver better value healthcare. Thank you for listening.